Thank you very much for the kind invitation, and I would like to thank the scientific committee for having invited me. It's a great honor for me to be here today with you. And my mentor, François Dreyfus, the son of Bernard Dreyfus, would have been very happy to be here. I will talk about when are erythroid stimulating agents effective and what we can offer after their failure. Okay, so here are my disclosures. So I will begin with two questions. Well, it is very simple, simple answer, but just to say, is it important to decipher the predictive factors of response to ESA in 2022? I think you can, I don't know if you can answer with the QR code or something like that. Because after the talk, I will, oh, no, it is not this one. I will repeat the questions and we will see if there are some modifications before and after the talk. So it is not the answers of my questions, but no problem. And which second lines of treatment do you use after ESA failure? So it is a kind of poll. You have several agents, and in which order you would propose these agents in second line after ESA failure. Okay, so HMA, transfusions, lenalidomide, and luspatercept, GCSF 12%. Okay, so let's start. So as you all know, ESA have EMA authorization since 2017, thanks to three randomized phase 3 trials, EPO-AN and ARCAD, which showed that in the EPO arms you had a significant improvement of erythroid response compared to placebo arm. So now in Europe, we have the authorization of ESAs for lower risk MDS patients, anemia with anemia and lower risk IPSS and without excess of blast. Several studies have shown that the response rate range between 40 to 60% according to IWG response classifications, and the mean median duration of response is about 2 years. There is no difference between the kinds of ESAs, like erythropoietin alpha or darbepoietin. It is an old meta-analysis study, but this study shows that there is no difference between erythropoietin alpha and darbepoietin. And the response rate depends more on the doses of ESA used. With a standard dose, you can get about 40–50% of a response rate, and a high dose, about 60 to 70%. So, what is the predictive factors of ESA failure? You have, during these last 20 years, several studies, and I will highlight some studies underlining these predictive factors of response to ESA failure. So here it is a European study collecting GFM, FISM, and Düsseldorf registries, and we have studied the predictive factors of response to ESA. We have set a score involving IPSS-R, EPO level, and ferritin level. And as you can see, when you have a high IPSS-R score, and high EPO level and a high serum ferritin level more than 350, but you have a lower response rate, about 40 to 20% of response rate against 80% if you have the favorable predictive factors of response. And with the rise of gene profiling, we have shown that the number of mutations can predict a worse response rate. And when you have more than 2 mutations, you have a lower response rate to ESAs. And this is confirmed by IPSS-M, which underlined the importance of gene profiling in MDS. And thanks to the IPSS-M score, you can predict leukemia-free survival and overall survival, and they involve about 17 variables of genes. And what is important is that thanks to this IPSS-M score, you can reclassify about 1/2 of patients with intermediate IPSS-R in a higher subclassification of IPSS-R. And this subcategory of patients, which are between the lower and the higher risk of MDS patients, could shift to higher classifications of IPSS. And in these patients, we should propose more earlier second-line treatments after ESA failure. So what is the importance of predicting response to ESA? This is these curves. We have shown in the French registry in the left and in an international study in the right that the duration of ESA and the primary resistance to ESA is predictive of AML incidence. And when you have a primary resistance to ESA, but you will have a higher AML incidence. So this is important to predict quite early the patients who will lose ESA response. So how to manage ESA failure? These last years, we have the new agents, luspatercept, which is a trap ligand of the TGF-beta superfamily signaling, and which is a GDF ligand trap, and which plays a role in the late stages of erythropoiesis. And so you have the phase 2 and phase 3 studies confirming the role of luspatercept in low-risk MDS patients. The phase 2 study has been demonstrated in low-risk MDS patients, all kind of low risk without and with excess of ring sideroblast. And you see the schedule every 3 months, subcutaneous way, and the response rate with 38% of red blood cell transfusion independence in all MDS patients. But you can notice that the response rate is lower in MDS without ring sideroblast patients, ring sideroblast. So therefore, the phase 3 medalist study have focused on MDS with excess of ring sideroblast. And you all know this study randomizing luspatercept versus a placebo with this kind of population. And you can see the response rate of 47% in the overall population. And the response rate being dependent, correlated with the transfusion burden rate, with a lower response rate in high transfused patients compared to a higher response rate in the low transfusion burden patients. So based on this study, luspatercept has been approved by FDA and EMA for MDS with excess of ring sideroblast. So this is one option for MDS with excess of ring sideroblast after ESA failure. Previous luspatercept, you had numerous studies with lenalidomide tested in low-risk MDS patients. You all know the studies in MDS del 5Q, which have demonstrated a high transfusion independence and cytogenetic response. And in the lower panels of the table, you can see the studies with lenalidomide in MDS non-del5Q patients with transfusion independence around 30 to 40%. And with synergy with erythropoietin, the arm lenalidomide plus erythropoietin being better than lenalidomide alone. So there is no FDA approval of lenalidomide, but in a practical way, you can use this in MDS refractory to ESA with the association of ESA, 10 milligram daily, 3 weeks out of 4. And in a 3-month trial, you can yield a response rate of 40% of patients. You can propose this option to patients with platelets more than 100 or absolute neutrophil count more than 1 giga. And with no prior use of HMA, as several studies have shown that the use of lenalidomide after HMA is yield a lower response rate than the inverse. What about hypomethylating agent trials? You can see several trials with diminished doses, diminished duration of use of azacitidine in low-risk MDS patients. You have 5 days trials and 3 days trials, and the last trial using the oral form of azacitidine. You can see that the response rate range between 12 to 25%. But the inconvenience of this option is infection rates and hospitalization rates. So therefore, you have, before talking about the 3-day trial, you have the oral form of azacitidine, the CC4A86, which was published recently, which yields 30% of red blood cell transfusion dependence, but more early deaths due to infections. So here it is interesting to see the phase 2 trials testing decitabine versus azacitidine, 3 days, so lower, shorter duration of use of HMA in low-risk MDS patients. And with this trial, you can see that there is an overall response rate of 70% with decitabine versus 49% in azacitidine. On the right, you have the overall survival curves and comparing decitabine and azacitidine, which favors decitabine in higher risk MDS patients. But when you see the overall survival of these patients after ESA failure, they are quite the same, independently of the use of HMA or lenalidomide. And you can see the curves, the yellow curves with HMA and blue curve with, black curve with lenalidomide, which is quite similar to the best supportive care patients after ESA failure. So what other options we can propose for these patients? Iron is very important on erythropoiesis, and perhaps we could use the interest of iron modulation after ESA failure. You know the regulation of iron metabolism by hepcidin, which is a hyposidermic property, and which is lowered in MDS patients due to the ineffective erythropoiesis, which increases erythroferron, which downregulates hepcidin. So you see here in the left the Valeria Santini's study, which showed the lower rate of hepcidin and hepcidin on ferritin ratio in MDS, especially with ring sideroblast. And on the right panel, you can see Michaela Fontenay's study about erythroferron and mis-splicing form of erythroferron in MDS with a ring sideroblast. And here again, they showed that hepcidin on ferritin ratio was downregulated in MDS compared to controls. And we have shown that lower hepcidin on ferritin ratio predicts a lower and shorter response rate to ESA in low-risk MDS patients, and this predicts a shorter response when you have a hepcidin ferritin ratio lower than 9. So this stresses on the role of iron metabolism and iron overload, which is damageable in leukemic stem cell and microenvironment in MDS. And we have shown that iron modulation by deferasirox, low-dose deferasirox, can impact erythropoiesis in vitro and impact ROS and NF-kappa B signaling pathway in erythroid progenitors. So we are conducting a translational study in France, the LODEFI trial, which which is testing a low-dose deferasirox in lower-risk MDS patients after ESA failure. The two last options are two new agents, imetelstat, which is interesting because it is an inhibitor of telomerase, and it has been shown in a phase 2 trial that it can yield about 40% of erythroid transfusion independence. And the mechanism of action is interesting because it inhibits telomerase activity, and it reduces H3 expression, and most importantly, it diminishes the variable allele frequency of SF3B1, so which has an importance on the clone, the leukemic clone. And recently, in this ASH meeting, there is an abstract which describes a prolonged transfusion independence with imetelstat, more than 1 year, which underlines the perhaps interesting biological properties of imetelstat on the leukemic clone. Roxadustat, which is a HIF stabilizer, has an interesting property because HIF regulates erythropoietin and the metabolism of iron, hepcidin. And by stabilizing HIF, you can increase the erythropoietin level and downregulate the hepcidin level and improve iron metabolism in MDS. This treatment is oral and used 3 times weekly. It is approved by EMA on chronic kidney disease, but the study is still ongoing for MDS patients. And on a preliminary report on the 24 patients, this compound yields about 38% of response rate in low-risk MDS patients, refractory to ESA. And last but not least, allogenic transplantation. Marie Robin, for the French group, has worked a lot on this idea. You know that allogenic transplantation can be proposed for intermediate high or very high MDS patients. But among the lower risk MDS patients, you have intermediate risk or higher risk IPSS higher risk MDS patients based on primary or secondary failure to treatment, to lenalidomide or HMA, based on the number of somatic mutations, the therapy-related MDS, the presence of myelofibrosis, and the presence of neutropenia or other lineage cytopenias. And therefore, in these populations, retrospective analysis of allogenic transplantation in low-risk MDS patients has yielded these curves of overall survival and progression-free survival. So the outcome could be improved by more selection of donors and of improvement of conditioning regimen. And in the French MDS allo-risk trial, the lower risk MDS patients refractory to ESA with other lineage cytopenias and refractory to second-line treatments were randomized on allogeneic transplantation based on the presence of donor or not a donor. And you can see that the overall survival was the same between the both arms, but so we have to improve more these results. I will go very quickly on the targeted options in low-risk MDS patients. We have the IDIOM and IDEAL trials in the GFM. You have several targets as TP53 or NPM1 or anti-TIM3 or macrophage modulation. And so to conclude, how we can treat anemia after ESA failure, acting via the immunome or the microenvironment with luspatercept and lenalidomide, acting on epigenetic deregulation with HMA, acting on erythropoiesis with erythropoietin iron modulation, if with roxadustat, acting on telomerase with imetelstat, and finally with allogeneic transplantation. So to conclude, the predictive factors of response to ESA could be IPSS-R, ferritin, a polyedval number of gene mutations. And if you can have this measurement, epsilon on ferritin ratio or flow cytometry. And ESA failure, they have a worse prognosis with higher AMLs incidence. So perhaps we could use these prognostic factors of response to ESA to propose earlier second-line therapies. And to summarize, luspatercept is approved for MDS with excess of ring sideroblasts, lenalidomide but outside marketing authorization, iron modulation, and the challenge is intermediate risk MDS. And I think in this meeting we will talk abundantly of IPSS arm and the novel classifications. Thank you for your attention. And so again, is it important to decipher predictive factors of response to ESA? Okay, yes, thank you. Good job. 100%, okay. And the second question. No, but the second question is more difficult because it depends on the patients you have in front of you. But which second lines of treatment do you use after ESA failure? So there is no poll, huh? No counting? No, I don't see the timer.
Go on. Can we have the
slide?
The answer to this? Okay.
Ah, okay. Okay, so the percentage has changed a little bit compared to the first lenalidomide, HMA. Okay, luspatercept more importantly. Okay, thank you for your attention.